So ladies and gentlemen, I present to you Professor Dr. Karl Fagerstrom with his title, Nicotine Safety, Dependence and Harm Reduction.
Hello to all of you at the ETMC conference. I am indeed, ETMA conference. I'm sorry I can't be there in person. I would have very liked to be there since I have had a glimpse of Malaysia and Kuala Lumpur before when a new smoking cessation medication was launched, Chantix or Champix, Varenicline. I was traveling around your beautiful country and happened to see Kuching and Melaka and a few more cities. So, but anyway, we do the best of the situation. So I'm here by the web, and I will today talk about nicotine, its safety, dependence potential, and harm reduction. Next. So this is my disclosure. I have been in touch with many companies and been consulting for very many companies. Next. To begin with, we should talk about the safety. And we can go immediately to the next slide where I will say that the safety of pure nicotine long-term is not really available. The only pure products for nicotine is the nicotine replacement products, and they are usually not used long-term, and no long-term studies are available. So we have to go to what is the second best, and that is the epidemiological data of snus from Sweden. Snus is very much used in Sweden, and snus contains tobacco, which contains nicotine, but snus also contains a good number of other substances, and one of them are susceptible to be cancerogenic, also nitrosamines, for example. So if we take the next slide, we can see that in Sweden, 100 years ago, we were actually using more snus than cigarettes. But cigarettes took off and became the dominant product for tobacco. But sometime around the 1970s, it was clearly known that cigarette was harmful. So it started to go down at the same time as snus went up. And today we use more snus than smoking cigarettes. In the next slide, we can see what the former director of FDA said about nicotine. Nicotine, while highly addictive, is delivered through products on a continuum of risk, and that in order to successfully address cigarette addiction, we must make it possible for current adult smokers who still seek nicotine to get it from alternative and less harmful consequences. Next. This resulted in Swedish snus to be the first and so far the only product to be recognized by FDA as a less harmful tobacco product. And some of the text from FDA is that the available scientific evidence, including long-term epidemiological studies, shows that relative to cigarette smoking, exclusive use of these specific smokeless tobacco products poses lower risk of mouth cancer, heart disease, lung cancer, stroke, emphysema, and chronic bronchitis. What needs to be understood here is that the Swedish snus, which is a product looks like a very small tea bag that you put under your upper lip, is far from the snus or smokeless tobacco you have in Southeast Asia and particularly India. So they should not be compared. Next. To sum it up, harmful effects of nicotine are that it clearly adversely affects the fetus and can complicate delivery. So here, all nicotine products, as many other products, sometimes coffee also, is not a good thing to ingest while you are, or ladies are pregnant. Nicotine can possibly increase the risk of diabetes type 2 in very heavy users. That have been found in Sweden with snus. Heavy users of snus have had a bit of an increased risk of diabetes type 2. It also seems to make things like myocardial infarction or stroke a bit worse if it happens and you are using snus, thus nicotine. But that is about all, and there are no clear evidence that it has anything to do with cancer, not even mouth cancer. There are, of course, also maybe interesting to mention that there are positive effects from nicotine. Otherwise, it would probably not be the world's second most used drug after caffeine. And that it is a cognitive enhancer. It can prevent Parkinson's disease, ulcerative colitis, and possibly multiple sclerosis. And more and maybe more common, appetite suppressant and increases energy turnover. So that is probably a reason why jockeys and ballet dancers are using nicotine to control their weight. Thanks. Next. So I'm ready to switch gear and talk a little bit about dependence. And next. We have acetylcholine receptors, which are there for the transmitter acetylcholine. This receptor also is opened and activated by nicotine. So we talk about as nicotinic receptors. And on this screen, we see the density of nicotinic receptors. The more white and red, the higher the concentration. So we can see that we have most nicotinic receptors in the brainstem and the thalamus, but across the whole of the brain, we have nicotinic receptors. And not only in the brain, of course, but throughout the body. But what's interesting here is the brain. So what happens when someone takes nicotine is that nicotine blocks these nicotine acetylcholine receptors. That means that it's difficult for the brain to carry out its normal function if a good number of receptors are blocked. So what does the brain do? It actually makes more nicotinic receptors. We call it upregulation. You get more, so the brain can work fine despite nicotine being there. So when you have taken nicotine for a while, we talk about tolerance, you have a brain that is made to work and function with nicotine. And it does not work and function so well when nicotine goes away. Then we have withdrawal symptoms, craving for usually cigarettes, and many other symptoms. And usually the number of receptors return to normal after 2, 3, 4 months. But for some, we wonder whether it at any time at all returns to normal. Next. And nicotine or tobacco dependence. Next slide, please. In the next slide, this is the slide before, please. In this slide, we see that the World Health Organization recognizes tobacco dependence as a disease in section F17. And there are 6 criteria here. And in order for diagnosis to be fulfilled, 3 of the criteria need to be present. This classification has actually not been very much used because in tobacco or nicotine science, because these criteria, they are general for all and similar to all drugs, whether it's amphetamine, heroin, or anything else. So it's a little bit unspecific. So in the next slide, we can see a test, a questionnaire, which I developed during the 1970s when I wanted to better diagnose the smoking patients that I saw. And so there are 6 questions. The most important ones are the first: how soon after you wake up do you take your first dose of nicotine? Because nicotine has a very short half-life. So there is actually no nicotine left in the circulation that can have a pharmacological response in the morning if you have been sleeping for 8 hours. So you are abstinent in the morning. And if you can go hours without taking nicotine, it seems that that abstinence is not as heavy as if the first thing you almost reach for when you get out of bed is a cigarette. So time to the first cigarette or nicotine dosing, together with the number of cigarettes or nicotine products you use per day, seem to be the most important ones. If we go to the next slide, we also have to be aware that this is not just a physical dependence. Next slide, please. There should be one slide before this one, I think. Yes, and with so much behavior that is required with smoking, you smoke maybe 15 cigarettes a day, 10 puffs per cigarettes, it's 150 puffs per day. There is a lot of conditioning that when you get into that environment, when you get into that mood, when you see that person, when you get, etc., you are conditioned to take a cigarette. It goes automatically. Smoking used to be seen as a bad habit before we knew so much about the nicotine dependence. It is, of course, also a very strong habit, sometimes on the verge of being a little bit obsessional. Smoking can be relaxing. You make a kind of an artificial break. You take a cigarette out of the pack, you light it, you take a couple of deep breaths, can be relaxing and relieve some tension and anxiety. And another thing which is important with all drugs, that is the speed of delivery to the brain. If that isn't fast enough, there will be no subjective effects and no dependence. The inhalation route is the fastest of all, even faster than intravenous injection. So the cigarette is ideal for creating dependence, and you have sort of fingertip control over the dose. You can take some deep puffs, you can take some light puffs, you can take many, you can take few, etc. And that's why a nicotine patch, which requires very little behavior, is really on the next slide. We can see the continuum of dependence from the highest, where I mentioned the cigarette, and then e-cigarettes, snus. In the lowest here, we have nicotine replacement products, and among them, the patch, the very lowest. I have, during my many years in this area, not heard of anyone starting with a nicotine patch and getting dependent. And also in smoking cessation, where nicotine patch is used, it's never any problem to stop with a patch, while with gum and lozenges, it can be a little bit of a problem to stop, since the dependence that was started by usually cigarettes is carried on a bit into the nicotine replacement products. Okay, next. So now we go into harm reduction. And what is important, and here we see the European Union, the prevalence of smoking in the European Union. Sweden is here. The use of tobacco is as much in Sweden as it is in most other countries in European Union, but most of it is used with snus, and very few are smoking in Sweden. And let's see what that has resulted in, this very different tobacco habit. Next. And this is again to show you the prevalence of daily tobacco smoking. Sweden is an outlier with less than 5% daily smokers in the adult population. Next slide. So nicotine, there should be another slide before this one, please. No, okay, next. Here, okay. So this slide is the most important slide I have. This is death rates attributable to tobacco, World Health Organization data. We look at the European Union here, and the median of European Union for regards lung cancer, other cancers, and cardiovascular. The country with the maximum death rate and the country with the minimum. This was the median death rate. And we see the median is 220 among the European countries. The countries with the least is 91, but Sweden is the outside lower with 87. That was lung cancer. If we look at other cancers, the average of European Union is 105 per 100,000. While Sweden is 36, clearly lower than the next lowest in the European Union. All cardiovascular, the same, 72 for Sweden, 170 for the entire European Union, and some countries as high as 600. All causes the same, of course, 222, much lower than the next lowest country in the European Union. If we go to the global burden of disease study with some fresh data, we see very much the same. Again, the European Union countries with the weighted mean, highest country with the highest rate and the country with the lowest, and then we have Sweden. In the total men population, for all causes, tobacco attributable death is 70, and 125 for the median in European Union. If another age bracket, the same, Sweden much less. But if we look at women, there is 52, which is actually higher than in the European Union median. And this, how come? Simply because the snus use has been a male activity. And women has up until now not really used any snus. So they have been using cigarettes. And that I think accounts for the difference, the huge difference between men and women. So it's kind of an experiment within the country. It's not the food of the country or the weather or anything else. It seemed to be the specific tobacco habit of the sexes. Can we now go to the previous slide, the slide before? So nicotine intake in perspective. When you use snus, the intake of nicotine is similar to that from cigarettes. So it cannot be that snus users are taking less nicotine than the cigarette users. The nicotine intake is about the same, but the harmful effects are very different, of course. So next slide, and next slide again, sorry. An interesting thing is also about to happen in Japan. We see cigarette smoking here. It is very stable, but going down a little bit. But something happened here, and that is heat, but not burned tobacco products. They look like this. You have a system that warms up the tobacco, so nicotine is distilled, you can say, out of the tobacco rod. But it's no combustion, it's no burning. and smoking starts to go down as these products go up. So there is a little bit of a communicating jar. It looks like that smoking is down and heat but not burn use is up. And the next slide, we can see that in my neighboring country, which is Norway, the very same is happening. This is cigarettes prevalence, smoking prevalence is going down at the same time as snus prevalence is going up. This does not say, and also of course for Japan, that there is a causal relationship between snus goes up and cigarette smoking down. We see an association here, but personally, I think that there is a bit of a causal effect that smokers are being aware that smoking is very harmful and is not even in much any longer. It's an outdated habit, and snus is less harmful, and therefore if they cannot give up smoking entirely, they go over to snus. And the next slide, please. So we are getting towards the end. Next slide. No, there should be one slide before that one here, nicotine in perspective. I think we can say that the purest nicotine products may have health effects not far from caffeine and most certainly less harmful effects than alcohol on users and non-users. Nicotine causes neuroadaptation and dependence varies between administration forms. Smokeless tobacco does have dependence, has abuse potential, but not to the same degree as cigarettes. Also, electronic cigarettes seem to be less dependence forming than traditional cigarettes, although they are dependence creating. Cigarette smoking lends itself very well to harm reduction because the combustion with the inhalation of all the not hundreds but thousands of harmful substances is affecting the body significantly. And that was what I had to say about the safety of nicotine, the dependence, and the potential for harm reduction. Next, thank you very much, and I hope you have a productive and pleasant conference. Bye-bye.